Welcome to The Explainer. Today we're talking about a really fascinating pathogen, one that was basically hiding in plain sight for years, Kerstersia gyiorum. We're going to look at how our modern lab tech finally brought it out of the shadows, and more importantly, what that means for us as microbiologists.
All right, let's just jump right in with a question for everyone at the bench. Think about this. Could there be an emerging opportunistic pathogen hiding in your lab right now? Maybe getting misidentified by the very systems you count on every day.
So, today's deep dive is all about Kerstersia gyiorum. And just so you know, everything we're about to cover comes from a comprehensive Gemini deep search. If you want to see all the primary sources and citations, they're all right there for you in the notebook document that goes along with this. All right, so here's our game plan. We're going to follow that classic bench-to-bedside journey. We'll start with what it looks like in the lab, get into the tricky parts of actually identifying it, and then move all the way to patient care and infection control. First up, what exactly is Kerstersia gyiorum, and why are we suddenly talking about it so much now? Why is it so clinically relevant all of a sudden? Well, it's an opportunistic pathogen, and it was first formally described back in 2003. It's part of the Alcaligenes family, and here's the key thing. You're almost always going to find it in patients who already have significant health problems or some kind of compromised site. So, this isn't a bug that's making otherwise healthy people sick. Okay, let's head over to the bench. Let's talk about what this thing actually looks like. The classic microbiological characteristics you'd see if you came across it in the lab. So, looking at the gram stain, it's a pretty standard gram-negative coco-bacillus. Nothing too crazy there. On blood agar, you're looking for these flat gray colonies, and they can sometimes have spreading edges. But the real tell, the most distinctive feature, is what you see on McConkey agar. It's a non-lactose fermenter, sure, but when you take your loupe and scrape the growth, you'll often see this really unique, subtle lavender hue. That is a fantastic clue. Okay, now for the biochemicals. What's really, really interesting here is the oxidase result. This is the big one, folks. It's oxidase negative. And that single test, that is the crucial differentiator that immediately sets it apart from its look-alike cousin, Alcaligenes faecalis, which, as you know, is almost always oxidase positive. The real story of this organism, the reason we're even talking about it, is all about identification. It's a perfect case study, really, showing the limitations of our old tech versus the incredible power of our newer tools. Think about it. For years, Kerstersia gyiorum was basically invisible in the clinical lab. The legacy automated systems, your Vitek 2, your API panels, they just couldn't see it. They'd either failed to give an ID at all, or worse, they'd misidentify it as something like Alcaligenes or Achromobacter. But then comes MALDI-TOF mass spec, which gives us a rapid, high-confidence ID, as long as it's in the database, of course. And then you have 16S rRNA sequencing, the absolute gold standard for confirmation. Honestly, these modern methods are the only reason this pathogen is on our radar today. So, okay, your lab has nailed the ID. Great job. Now what? What does a Kerstersia gyiorum infection actually look like when you get to the patient's bedside? Well, there are two classic presentations you'll see again and again. First, chronic ear infections. We're talking chronic separative otitis media, or CSOM. And second, these stubborn, non-healing skin and soft tissue infections, like those nasty ulcers on the lower limbs. And the key risk factors? They're pretty much the usual suspects for an opportunist: diabetes, chronic wounds, immunosuppression, and, of course, advanced stage. But here's something really important to remember. The clinical picture is getting broader. As we get better at identifying it, we're seeing it pop up in new places. We now have multiple reports of Kerstersia gyiorum from respiratory samples, especially from patients with trachs. And there's even been a documented case of bacteremia and sepsis. This is huge because it proves this isn't just some harmless colonizer. It can absolutely cause serious invasive disease. All right, now for probably the most critical clinical question of all. How in the world do we treat this thing, especially when there's basically no official guidance out there? So this is a big problem. From a susceptibility testing point of view, we're kind of flying blind. We're in this breakpoint void. Neither EUCAST nor CLSI have any species-specific clinical breakpoints for Kerstersia gyiorum. And that makes interpreting your MIC values and trying to predict if a drug will work a major challenge for the clinicians. And before we even start talking about which drugs might work, I have to give a critical warning.
There is a very concerning trend popping up in reports from all over: increasing resistance to fluoroquinolones. We're talking ciprofloxacin, levofloxacin. This means just throwing a fluoroquinolone at it empirically is a really bad idea. It's just too unreliable.
So, what do? How do we adopt? Well, if we look at the Dutch guidelines as a kind of model, it's clear that our standard go-to therapies just won't cut it. For chronic otitis, you'd have to ditch the usual quinolone drops, and if the susceptibilities look good, maybe consider polymyxin B drops or oral trimethoxazole/sulfamethoxazole. And for a skin infection, forget about standard flucloxacillin. That's completely useless. For a really severe case, you're looking at needing something much bigger, like IV pipraxilin tazobactam. And the key in all of this? It's always guided by the antibiogram. And this picture is backed up by case reports from all over the world. The same agents keep popping up with successful outcomes: broad-spectrum beta-lactams, piperacillin tazobactam, and even carbapenems for the really severe infections. And trimethoprim sulfamethoxazole keeps showing up as a solid oral option, especially for those ear infections. But what's the one common thread through all of these success stories? Every single one was guided by in vitro susceptibility results. No guesswork. Now, what about kids? The experience there is still pretty limited, but in the few cases that have been reported, mostly chronic otitis media again, it looks like the treatment principles are exactly the same as for adults. It all comes down to relying on that susceptibility report and, of course, adjusting the dose based on the child's weight. Okay, so finally, let's wrap up with infection control. How do we stop this thing from spreading inside the hospital? And what's the big ultimate takeaway from its whole story? When it comes to infection control, most of the time your standard precautions are going to be enough. However, the decision to escalate, to step things up, is driven entirely by the antibiogram. The moment you see a multi-drug resistant isolate, say one that's resistant to fluoroquinolones, you absolutely have to escalate to full contact precautions. No question. That's how you prevent nosocomial spread. We're talking a single room, gowns and gloves for anyone who enters, and dedicated patient equipment. And this quote here just says it all, doesn't it? It brilliantly sums up the core lesson here. The story of Kerstersia gyiorum isn't about some brand new superbugs suddenly appearing out of nowhere. No, it's about our new powerful technology finally letting us see a pathogen that was there all along, just hiding in plain sight. So what does this all mean? The bottom line for every single clinical microbiologist out there is this: your work at the bench, accurately identifying this organism, that is so much more than just a lab result. It is the critical first step. It's the single most important action that directly leads to the right patient therapy and helps protect the entire hospital. And that wraps up our deep dive on Kerstersia gyiorum. Hey, if you found this useful, please subscribe for more explainers just like this one. And we really, really want to hear from you. Have you seen this organism in your lab? What kind of challenges did you face with it? Please share your own experiences and your feedback down in the comments below. Let's get a conversation going.